So good afternoon. I'm Rebecca Brady, one of the pediatric infectious disease attendings. We're going to be discussing congenital infections. My three objectives are first, to recognize clinical manifestations that are suggestive of congenital infections. Number two, to review examples of congenital infections. And third, to plan the diagnostic evaluation for suspected congenital infections and their subsequent management. So we're going to first start with some definitions regarding routes of acquisition of infection. So congenital refers to those infections that are transmitted across the placenta. The risk of transmission varies depending on the trimester of pregnancy during which the maternal infection occurs, and the severity of infection depends on the stage of infection at which the maternal infection occurs. Perinatal is usually referred to infections that are acquired just prior to birth, often after the rupture of membranes or as the newborn passes through the birth canal. And the term postnatal refers to acquisition after birth. So with congenital infections, you may have learned a mnemonic back in medical school, TORCH. We don't use that as much anymore, but it can be useful to remembering what the different infections are. So the T may stand for Toxoplasma gondii, which causes toxoplasmosis, or Treponema pallidum, which causes syphilis. O is others, and there's a very large group of those, including hepatitis B, human immunodeficiency virus, and Zika virus. R is Rubella, C is Cytomegalovirus, and H is herpes simplex virus. With herpes simplex virus, though, intrauterine or congenital transmission is rare. It's most often acquired as the newborn infant passes through the birth canal, so it's usually really a perinatal infection. We're going to start with a case. So we have a male newborn infant born at 37 weeks gestation. On his initial exam, he's small for gestational age. His mother had testing at 12 weeks of gestation that showed an RPR of 1 to 8, a Treponema pallidum particle agglutination test that was positive, Rubella IgG test that was positive. His mother was treated with azithromycin because she had a history of anaphylaxis to penicillin, and just prior to delivery, the mother's repeat RPR was 1 to 4. On physical examination, this is a small neonate with jaundice. His weight is 1.97 kilograms. Length is 42.5 centimeters. Head circumference is 27 centimeters, and all of those are less than the 3rd percentile for gestational age. He has scleral icterus. There's copious blood-tinged rhinorrhea with occasional crusting noted of his nares. He has generalized lymphadenopathy with hepatosplenomegaly and generalized desquamation. His laboratory studies show a white blood cell count of 12,000, hemoglobin is 9.5, platelets are 250,000, direct bilirubin is elevated at 3, his Toxoplasma IgG is positive, his Cytomegalovirus IgG is positive, the cerebrospinal fluid is traumatic, and there's an RPR pending. So of the following, the most likely cause of this boy's disease is Cytomegalovirus, Rubella virus, Toxoplasma gondii, or Treponema pallidum. If I were doing this live, I would ask you to raise your hands or somehow indicate the answer. So I'm going to go ahead and proceed now, but I hope you're thinking of what your potential answer is, and then as I go through, see if it matches. So first we have to think of what clinical manifestations are that suggest congenital infections. So one is obviously intrauterine growth restriction, hepatosplenomegaly, jaundice, certain eye anomalies including cataracts and chorioretinitis, impaired hearing, various rashes, and neurologic anomalies that include seizures, microcephaly, and hydrocephalus. The evaluation always starts with a thorough maternal and family history and physical examination. You should plot the height, weight, and head circumference on a growth chart that's appropriate for gestational age, and that will help in determining if the baby has generalized small for gestational age, or may just have an isolated parameter that's low, for example, weight or microcephaly. We usually do a formal ophthalmologic examination because we're actually needing to get a good look at the fundus for retinitis. Hearing evaluation, all babies do get the newborn screen. Those that fail and have actual concerns for congenital infection, we usually do the extra step of doing a formal auditory brainstem response test. We usually do a CBC that includes differential and platelets, especially looking for anemia and thrombocytopenia, looking at the transaminases, elevated bilirubin, especially a direct bilirubin, and then you may do central nervous system imaging or cerebrospinal fluid analysis. So we're going to start with the congenital infection that's actually the most common, which is the C or cytomegalovirus. So if you go to a daycare, there's a lot of those little toddlers that have CMV and are asymptomatic. And with that group care of children that facilitates the spread of CMV, especially among toddlers, that leads to a high prevalence among attendees. And then subsequently, those little toddlers may take CMV home and pass it to their mothers who are pregnant. So that's often a clue with congenital CMV, that there is a toddler in the home that the mother is currently taking care of. So the transmission of congenital CMV infection to the fetus can occur anytime during gestation. The risk is greatest if the mother has the primary CMV infection during gestation, meaning that she's never had CMV previously in her life. The majority of these infants with congenital CMV are going to be asymptomatic, so that's actually the good news. So if you want to put congenital CMV into perspective, is there any way to do a pointer or anything here or not, like that?
It'll capture the mouse.
Okay, so if we start out per year, there's about 4 million births, and anywhere from 0.2 to 2% are infected with CMV. So there's about 40,000 babies born per year with congenital CMV infection. Over 90% are going to be asymptomatic. That's going to be about 36,000. Less than 10% will be symptomatic. That's 4,000. Of those who are symptomatic, about 90% have sequelae, and about 10% will die. This other 36,000 or so up here who look to be asymptomatic at this point, actually about 15% will go on to develop later sequelae. And one of those big ones is hearing loss. They may also have some developmental delays. So even if you identify the infant at birth with congenital CMV and they look asymptomatic, we still usually follow up, especially their hearing and development, through that first 5 years of life. So this is looking more at those babies that do have symptoms with their congenital CMV infection and what those symptoms are. So those include prematurity, intrauterine growth restriction, petechia, purpura. These are often referred to as the babies with the blueberry muffin rash, and that is actually a site of dermal erythropoiesis. They have hepatitis, hepatosplenomegaly, jaundice. They may have pneumonitis, thrombocytopenia. If you do a head ultrasound, the characteristic of congenital CMV is periventricular intracranial calcifications. So if you think of CMV, there's a C and there's a V, and the V is the periventricular calcifications. They may have chorioretinitis. Hearing loss isn't always present at birth. It may be a late manifestation. The way to make the diagnosis of congenital CMV is to identify the virus. Usually here we do it by PCR. You can collect urine. This can just be a bag urine. It doesn't have to be sterile, but this urine specimen does have to be collected within that first 21 days of life, because if you collect and diagnose it beyond then, it's hard to know if the CMV was really a congenital infection versus one that was acquired later. There is treatment now for congenital CMV infection. The recommendation is currently 6 months of oral valganciclovir if they're symptomatic. And in the study that was done, reported by David Kimberlin through the Collaborative Antiviral Study Group, which was placebo-controlled, this 6 months of oral valganciclovir did improve hearing and neurodevelopmental outcomes, at least out to 2 years of age. The risk with valganciclovir is neutropenia, but there is less risk with oral valganciclovir as compared to the previous therapy that we had to offer, which was intravenous ganciclovir, which had more neutropenia, obviously the increased risk with having to have a PICC line in a young infant. With prevention, pregnant women should practice good hand hygiene with young children. Currently, routine serologic testing of pregnant women is not recommended. And if you do identify a newborn with congenital CMV infection, they're managed with just standard precautions. The next congenital infection that we're going to be discussing is congenital syphilis, which unfortunately syphilis in adolescents and young adults is increasing, and therefore we're also seeing more congenital syphilis. About 2/3 of infants with congenital syphilis are asymptomatic at birth. This other 1/3 of infants have irritability, failure to thrive, again hepatosplenomegaly, generalized lymphadenopathy. They have chronic watery or blood-tinged nasal discharge, which is often referred to as snuffles. They have copper-colored, flat or bumpy maculopapular rash. It's often on the palms and soles. There can also be various rashes around the mouth, genitalia, and anus. CNS disease, chorioretinitis. They can have a severe congenital pneumonia referred to as pneumonia alba. And over time, there's loss of nasal cartilage leading to a saddle nose appearance. Another important clue with congenital syphilis is that it can cause a periostitis of the long bones. So if you're thinking this sounded like the baby in the vignette that I presented earlier, you are correct. So all pregnant women should be screened with an RPR, a rapid plasma reagent test. If the mother has a positive RPR, that should be confirmed with a troponemal test. That usually here is a troponemal pallidum particle agglutination, or TPPA antibody. You basically then are comparing the mother and the infant's RPR and doing a physical examination. So is the infant's RPR positive? Does the infant have symptoms that would be suggestive of congenital syphilis? Was the mother treated with penicillin during delivery, and was the treatment completed more than 4 weeks before delivery? If you think back to the vignette, the mother did not receive penicillin. She received azithromycin, and that is not really recommended. The recommendation is if you're pregnant and you have syphilis, you receive desynthesization therapy and get penicillin, because it's the drug that has the most proof in preventing congenital syphilis in the infant. There are algorithms in the current American Academy of Pediatric Red Book, and this is very complicated. I won't go through it, but every time I probably get a call from a nursery about one of these babies, I refer to this in the Red Book and go through it and see where we're at. They actually have included the reverse testing, because many obstetricians now are actually starting with more the troponemal pallidum specific test and then doing the RPR as a second step. And so the various different scenarios, basically the pieces that you need to know was mom treated? Was she treated with penicillin? Was it more than 4 weeks before delivery? Is there a risk that mom could have gotten reinfected? What's the infant physical examination? And usually if there's any concern that these babies potentially have congenital syphilis, we will err on the side of treating them. So these are some of the additional evaluations as you go through that algorithm that you may be asked to do, including a CBC with differential platelets, analysis of the cerebrospinal fluid. Here the test for syphilis is a VDRL. You're also looking at cell counts and proteins. The long bone films looking for the periostitis, chest radiographs, the hepatic profile, again the auditory brainstem response, neuroimaging, the ophthalmology exam to look for chorioretinitis. If we do decide to treat an infant for congenital syphilis, it's 10 days, all IV, aqueous penicillin G. And then the baby needs to be followed up, and most of the time the community pediatricians will ask ID to see and help them follow these babies up. So the follow-up RPR tests are done at 2, 4, 6, and 12 months of age, along with a thorough physical examination. These are some of the other congenital infections. So hepatitis B, pregnant women should have a hepatitis B surface antigen, even if they've come in and not received prenatal care. That's one of the tests that's usually pretty quickly done in labor and delivery. If the mother is hepatitis B surface antigen positive, the baby gets not only the routine hepatitis B vaccine, but also hepatitis B immune globulin, and the goal is to try to get that H big within 12 hours of birth. With HIV, the goal is really treating the pregnant HIV-infected woman to achieve an undetectable HIV viral load to minimize transmission to the newborn. Zika as a congenital infection has just really gained attention over the past 5 years or so. It mainly has CNS manifestations, including microcephaly with a partially collapsed skull, then cerebral cortices with subcortical calcifications. They have hypertonia, which is a little different than many of the other congenital infections where the baby has decreased tone. And there's extrapyramidal involvement with tremors and posturing. So it's probably not something you're going to encounter here in the US, but you have to ask potentially if they've been in South America. Another congenital infection is toxoplasmosis. It's asymptomatic in about 70 to 90% of cases. I think as you're going through here, you'll start to see patterns that many of these are features of all these different congenital infections. So again, you have prematurity, intrauterine growth retardation, the petechial or the maculopapular rash, lymphadenopathy, hepatosplenomegaly, thrombocytopenia, hydrocephalus, microcephaly. Here are the calcifications that were different. In toxoplasmosis on your head ultrasound, you'll have more diffuse intracranial calcifications. So that can be a distinguishing feature on a board exam if you're trying to distinguish between toxoplasmosis and CMV. Also cataracts, chorioretinitis. With this, it's very hard often to diagnose, so we usually use the Toxoplasma Serology reference laboratory in Palo Alto, California. They can, in addition to just doing the routine IgG and IgM, also do a serum IgA. They can do PCRs on the spinal fluid. They can also culture the placenta and the CSF. This is a very complicated treatment if you have to treat an infant for congenital toxoplasmosis. It includes 3 medications for at least a year: pyrimethamine, sulfadiazine, and leucovorin. These drugs can cause bone marrow suppression, and so the baby has to come in and receive CBCs with differentials pretty frequently. So we really want to be for sure of this diagnosis before we go committing the baby to this therapy. Congenital rubella, hopefully you won't see much with people being vaccinated, especially women before they reach childbearing potential. But there's a lot of resistance to vaccines, vaccine hesitancy, so there probably are young women out there of childbearing age who are not immune to rubella. If she does acquire rubella during pregnancy, that virus can get across the placenta and infect the fetus. The greatest risk is going to be if that infection occurs during the first trimester, and there about 85% will be affected. Again, sensorineural hearing loss, cataracts, glaucoma. One of the differences here is the heart defects, including patent ductus arteriosus and pulmonary stenosis. Again, microcephaly, mental retardation that may not be picked up until the child's older. Again, some bone problems, liver and spleen damage, and that blueberry muffin appearance. These babies are really shedding rubella for a long time, so they are contagious through most of that first year of life. The testing is rubella RNA real-time PCR, which may stay positive for that whole year as they're shedding the virus. You have to be careful with rubella IgMs because there's false positives and false negative test results. This one, there's no treatment, it's just supportive care. And then as I mentioned earlier, HSV or herpes simplex virus is really more of a neonatal or perinatal infection. It can be intrauterine. but that's much more rare. With women, we often ask, does the mom have a history of genital herpes? And actually, if the mom's had genital herpes for many years, she probably has antibody that is going to be passed to that baby. And so that baby is going to be infected. We really probably have to worry more about the mothers who don't know that they have genital herpes. They've acquired their primary genital infection during pregnancy, and that's one of the highest risk groups. The infant then requires HSV, usually perinatally or postnatally. The different manifestations include skin, eye, and mouth disease. Those babies usually present between 4 and 11 days of age. And if you look there, there's some little vesicles on an erythematous base on the baby's mouth. More disseminated disease, it usually affects the liver, so you can actually have hepatitis and even acute hepatic failure, and also pneumonitis. And then the other place the virus tends to like to go in these young babies is the central nervous system, causing a meningitis or meningoencephalitis. That usually peaks a little bit later, about 7 to 21 days. The diagnosis we rely on is the polymerase chain reaction. You can detect the virus in the lesions. You can also detect the virus in the cerebrospinal fluid. Here the treatment is intravenous acyclovir. With the SEM disease, it's for 14 days. With the more disseminated and CNS disease, you usually treat for 21 days. And finally, I have some references here. So your American Academy of Pediatric Red Book has most of the chapters on many of these, including syphilis. There was a guideline published in 2017 for the diagnosis, treatment, and prevention of congenital toxoplasmosis. And then there's some other recent references on there for torch infections. And the one that you're going to see probably and they have to think about the most is congenital CMV. So I have just a short little 15-minute consultation reference on diagnosis and management of congenital CMV. I'd like to thank you for your attention.